Thank you, Mr President. I rise today to speak on this bill and to indicate that I will not be supporting it in its current form. As a woman and a mother, there are several elements of the bill that I find very concerning. First and foremost, the removal on gestational upper term limits on the termination of a pregnancy. Before outlining my opposition to this bill in its current form, I'd like to state for the record that I am not against the move of the abortion legislation away from the Criminal Law Consolidation Act and into its own standalone Health Act. It is my understanding that in the last 50 years no woman has ever been prosecuted for accessing an abortion. What I am against are the changes to allow lawful abortion up to birth, and I also have concern with some of the early medical abortion legislation changes, particularly around rural and regional women and duty of care. Mr President, current legislation allows for termination up until proof of fetus or viability of a fetus, which is defined in the Act as 28 weeks. This can be done on grounds of physical or mental health of the mother, or if the baby has such abnormalities that deemed it to be severely handicapped. Over 28 weeks of gestation, abortion is illegal, except in circumstances when it is done in good faith to preserve the life of the mother. This is because society recognises that the baby is viable, feels pain and is capable of living externally independent of its mother. Over a number of decades, Mr President, we have reached the point where, due to advances in medical technology, the threshold of viability has shifted from 28 weeks to 22 weeks and 6 days. In fact, according to the Department of Health, the chance of survival in a baby born between 23 and 24 weeks of age who receives intensive care is 50%. The new legislation correctly identifies the fact that the viability of a fetus occurs not at 28 weeks, but at 22 weeks and 6 days. And I commend the Attorney-General and the other PAYs for acknowledging and recognising this important factor. The bill also removes subsection 7, which states that it is illegal to abort a child after proof of fetus or viability except to save the life of the mother. It will no longer be an offence to have an abortion at any stage up until birth for reasons that a medical practitioner deems as medically appropriate. This broad term, Mr President, poses significant risks that medical practitioners may be pressured to perform late-term abortions due to psychosocial reasons. The reality is that although the percentage of terminations in South Australia post-20 weeks is small, in 2017, 49.5% of these were for psychosocial or mental health reasons. When speaking on the bill on the radio, the Attorney-General spoke about possible situations when late termination is required. I'd like to bring this to the attention of the chamber, as I feel there needs to be some clarification on the definition of pregnancy termination, and I feel the bill does not address this appropriately. The bill defines termination as an intentional termination of a pregnancy in any way, including, for example, by A, administering or prescribing a drug or other substance, or B, using a medical instrument or other thing. What this bill does not define, or rather fails to recognise, is that there are two clinically and ethically distinct ways of terminating or ending a pregnancy. The first method is abortion, where the mother and baby are separated with the intention of producing a dead baby. The second method is early delivery, where the mother and baby are separated with the intention of producing a live baby. Both of these methods are terminating a pregnancy, but one produces a very different outcome to the other. The Attorney-General said, when asked about whether late-term abortion can occur if necessary for the physical or mental health of the mother, it is possible. The medical practitioners are the ones who identify whether there's risks to the health of the mother. There are two exceptions where occasionally this is called upon. One is where the life of the mother is at risk, and that will be maintained in the legislation, and if the life of another fetus is at risk. And I think what people don't always appreciate, it's not women who go along to say suddenly, I realise I don't want a child and I'm 7 months pregnant. It's actually a circumstance, for example, that might have twins, and the medical assessment is that one's at risk, and therefore to save one, a termination needs to be at least considered. End of quote. I do know that this situation does occur from time to time, Mr President. As a mother who has carried twins previously, I'm aware of the number of risks that twin pregnancies can have, such as twin-to-twin transfusion syndrome. However, I would argue that in this situation there are several advanced medical procedures that can be effected to assist one or both fetuses, or an induction of labour would be the likely resolution where both babies can be delivered via caesarean and cared for in the appropriate medical setting. So I think, Mr President, we need to be very careful in the use of our language when debating this bill, because the early induction of labour or preterm delivery via caesarean to be able to care for these children in a controlled, safe, outside environment is very different to the termination of the life of a child by means of lethal injection before dilatation and evacuation of that child. However, Mr President, I do understand that there may be very tragic circumstances that can occur in a pregnancy. Circumstances in which an abnormality may be picked up, particularly at weeks 20 and 26 weeks, between weeks 20 and 26 weeks of pregnancy, with twins, that may mean that it is necessary to terminate the life of one baby in order to save the life of another. The current legislation, Mr President, already allows for this up to 28 weeks. However, as the bill identifies that fetal viability begins at 22 weeks and 6 days, I think there needs to be provision for this. My understanding is that this is not common, and there are usually advanced medical procedures that can be attempted in utero. But I do think there needs to be a specific provision for this, for those cases that are perhaps at 23 weeks of pregnancy, where a medical condition provides significant risk for one or both of these babies and which cannot be helped in utero. That is why I'll be moving an amendment to Section 6 of the Pregnancy Termination Bill to allow for termination of a pregnancy for a person who is more than 22 weeks and 6 days pregnant if two medical practitioners are consulted and consider that in all the circumstances the termination is necessary to preserve the life of the mother or to save another fetus. When abortions are performed to save a woman's life or the life of another fetus, there needs to be a distinct intention that one life must be saved to prevent the loss of both lives. Mr President, I also acknowledge and understand that there are some terrible, awful situations where congenital or other anomalies may be picked up at a later time during gestation, say in the second trimester. Anomalies or abnormalities which are not compatible with life. And in such situations, parents may need to make a heartbreaking decision to terminate the pregnancy. I understand that these are tragic circumstances, and this is also acknowledged in my amendment to Section 6, which allows for a termination after 22 weeks and 6 days if there is a significant risk of serious fetal anomalies associated with the pregnancy that are incompatible with survival after birth. Mr President, whilst in some extenuating medical circumstances late-term abortions are necessary, they should never become routine. Many members in this chamber claim that they won't become routine. I reply, let's ensure they don't, by legislating for those situations that require it, but maintaining the protections for those situations that don't. Because, Mr President, 22 weeks and 6 days is 5 months through a pregnancy, and I would argue that that is plenty of time for a woman to make a decision as to whether they want to continue on with a pregnancy or not. And for those circumstances where that does not occur before 22 weeks and 6 days, then there are other options for these women, such as adoption. Mr President, there are many published risks to a woman associated with late-term abortions, including uterine perforation, Asherman syndrome, where there is scarring inside the uterus and cervix leading to reduced future fertility, retention of the placenta or fetus, known as incomplete abortion, excessive bleeding or hemorrhage leading to the requirement for a blood transfusion, infection or sepsis, and general anaesthetic and operative complications, not to mention the studies published on the post-traumatic stress disorder associated with late-term abortions in women. Mr President, 2 large-scale quantitative research papers in S.F. Goffberg's paper Abortion Complications and L.A. Bartlett, C.J. Berg, H.B. Schulman et al.'s paper Risk Factors for Legal-Induced Abortion-Related Mortality have revealed that second trimester and third trimester abortions pose most serious risks to women's physical health compared to first trimester abortions. The abortion complication rate is 3 to 6% at 12 to 13 weeks gestation and increases to 50% or higher as abortions are performed in the second trimester. Another significant quantitative study was done on late-term elective abortion and susceptibility to post-traumatic stress symptoms by Priscilla Coleman, Catherine Coyle and Vincent Roux. The purpose of this study was to test the hypothesis that women who undergo second and third trimester abortions would be more traumatised than their peers who experience first trimester abortions, as evidenced by significantly higher rates of PTSD symptoms. After instituting statistical controls for race, marital status, formal education, number of abortions, number of years since the abortion, mental health counselling and hospitalisation for emotional problems before the abortion, meaningfulness of the respondent's religion, and a childhood or adult history of physical or sexual abuse, all of the group differences were in the hypothesised direction, but only a few were statistically significant. Specifically, the difference in intrusion subscale scores was statistically significant. Intrusion involves an increased tendency to have persistent or unwanted re-experiencing of the traumatic event in the form of recurrent or distressing memories, flashbacks and hyperreactivity to any stimuli associated with trauma. In addition, when individual PTSD items were examined, the late-term group was found to report more disturbing dreams, more frequent reliving of the abortion and more trouble falling asleep. The study also found that 52% of those women who had had early abortions had PTSD, while 67% of those who had late-term abortions defined as second and third trimester abortions had the disorder. Thus, those women having late-term abortions were more likely to experience severe anxiety. And there is also the psychological impact on the healthcare team in the provision of the late-term abortion involving feticide. A recent article about feticide and late termination of pregnancy in the magazine of the Royal Australian and New Zealand College of Obstetricians and Gynaecologists stated, and I quote, "One infrequently discussed aspect of late abortion is feticide, where specific interventions occur to ensure the death of a fetus prior to expulsion. Unintended live birth after abortion can be emotionally difficult for many, although not all, women, and poses difficulties for health professionals, both in terms of process and emotion. In general, feticide is performed by ultrasound specialists who have skills in accessing the fetal circulation to install intracardiac potassium chloride or intraphenic lignocaine, resulting in cessation of fetal cardiac activity prior to the commencement of the termination procedure." It goes on to say, little consideration has been provided to the psychological impact on the healthcare team in the provision of a feticide service. Mr Acting President, the bill does have a clause relating to registered health practitioners being able to conscientiously object to performing or assisting in performing a termination, as does the existing legislation. However, I have concerns about regional or remote medical practitioners who are already under pressure to perform additional procedures given their locations. If a woman presents to a rural medical practitioner for a late termination procedure who has a conscientious objection to abortion and perhaps is the sole doctor in the region, and she says to that doctor, "I have no more mode of transport, I cannot afford to travel, you are my only hope," what is the medical practitioner supposed to do? Is he not bound by a duty of care? These are questions I would like answered in this bill. In the AMA's statement of conscientious objection, they state under point 2.4, and I quote, "The impact of a delay in treatment and whether it might constitute a significant impediment should be considered by a doctor if they conscientiously object, and is determined by the clinical context and the urgency of the specific treatment or procedure. For example, termination of pregnancy services are time-critical, whereas other services require less urgency, such as IVF services." End of quote. Mr Acting President, this highlights the significant pressure on rural and regional GPs, as it seems to me to suggest if there is not a convenient, timely alternative option for a patient, the GP should reconsider his conscientious objection. Mr Acting President, my other concern with this bill is its ability to allow a registered health practitioner who is not a doctor to prescribe the drugs mifepristone and misoprostol, or the MS2 step, as it is so often referred to as, for at-home abortions without the clear need for a medical practitioner's input. Part 2, Section 5, subsection 1b states that a termination may be performed on a person if, in the case of a termination performed by any other registered health practitioner acting in the ordinary course of the practitioner's profession, the determination is performed by administering a prescription drug, the termination is performed on a person who is not more than 63 days pregnant, and the registered health practitioner is authorised to prescribe the drug under Section 18 of the Controlled Substances Act 1984. Mr Acting President, when you look at who is able to prescribe a prescription drug within the Controlled Substances Act 1984, it states that this person may be a medical practitioner but also can be a nurse practitioner or a pharmacist. I have concerns with a nurse practitioner or a pharmacist being able to prescribe these drugs without the requirement for a medical practitioner to deem it safe to do so. Mr President, the Honourable Tammy Franks, in her first reading speech of her Statute Amendments Abortion Law Reform Bill, spoke about the lack of access to medical abortions for rural women and the barriers to their health care. I wholeheartedly agree with the honourable member. When it comes to regional health care, it is well known that those of us in the country face challenges with distance when accessing health care. However, it would be irresponsible for members in this place to support convenience over best medical practice for rural women. Under the proposed legislation, there are no safeguards to ensure that a medical practitioner has deemed the pregnancy termination to be safe to do so. Mr Acting President, this is paramount. According to the TGA, there are a large number of situations or contraindications where the MS2 step should not be prescribed, which requires obtaining a thorough medical history. These situations include if there is a suspected or confirmed ectopic pregnancy, if there is an intrauterine device present, if there is an uncertainty in gestational age, in the situation where the mother may be suffering from chronic adrenal failure, if the mother is on long-term corticosteroid therapy, and if the mother has a coagulopathy or hemorrhagic disorder or is taking anticoagulants for another condition, to name a few. Therefore, Mr Acting President, for the health and well-being of these women, these rural women, it is critical that a medical practitioner performs a thorough examination of these women and performs or assesses an ultrasound to ensure that there are no complicating factors before the prescribing and administration of both mifepristone and misoprostol. So, Mr Acting President, this is why I will be supporting an amendment to the legislation to ensure that any termination by a registered health practitioner is done so only after a medical practitioner has determined that the termination is safe to do so, because this really is about the duty of care to these women and ensuring that medical procedures are conducted in a safe manner. Importantly, the TGA guidelines for the MS2 step state MS2 step should only be prescribed by doctors with the appropriate qualifications and certified training. Ectopic pregnancy should be excluded, an intrauterine uterine device must be removed, consent obtained, and the patient must have the ability to access 24-hour emergency care if and when required for incomplete abortion or bleeding. In addition, Mr Acting President, the current recommendations from SA Health on termination of pregnancy in the first trimester is that women should not undergo a medical abortion if they live more than 1 hour away from emergency services such as an ambulance service or a hospital. I believe this is sensible and should be stated in the legislation to avoid any doubt. Mr Acting President, many rural and remote communities have limited access to emergency services. Being a woman and mother living in the country, I am acutely aware that whilst we must look to provide better services in the regions, we must also ensure that these services are safe. We, as members of parliament, have a duty of care to ensure the safety and well-being of our citizens and communities. SA Health also currently advise that a woman needs to have adequate support for the process, including a support person to drive her home and or return to the hospital via car or ambulance in the case of profuse bleeding necessitating urgent treatment. They also state that the woman must be advised that if she has heavy bleeding, she must present to the emergency department for urgent assessment and that urgent dilatation and curettage may be required. Whilst I understand that these complications are not common, they can and do occur, and it is why it is necessary that we legislate that a woman should not undergo a home abortion if they are more than 50 kilometres away from a hospital or ambulance service. Mr Acting President, during commentary about this legislation before us, much credit was given to the then Attorney-General, the late Honourable Robin Rhodes-Milhouse QC, on his so-called progressive reform of abortion laws in 1969 in South Australia. Mr President, whilst at the time the reform was popular, I'd like to quote the late Mr Milhouse from an article written in the Advertiser from 2014 entitled "Robin Milhouse's Regret." After 45 years of carrying a growing burden, the Honourable Mr Milhouse QC confided that, and I quote, "I deeply regret that the medical profession and the lawyers interpreted the law too widely. It has become abortion on demand. I did not intend it to be that. I have taken the rap for it. It is something I regret." Mr Acting President, this interview is pertinent, as it is a direct admission of how the intent of legislation is often not the reality. It is our job as members of parliament, but particularly as members of the Legislative Council, to scrutinise the legislation to ensure that the practical outcomes of a bill are what is expected and intended. Mr Acting President, most of us know someone that has been confronted with the decision of whether to terminate a pregnancy. It is an incredibly difficult decision. But the decision facing the parliament is not about access to early terminations, which are currently provided in a safe medical environment and should continue to be done as such. It is a decision about the ethical and moral implications of late-term abortion not associated with specific extenuating medical circumstances. Mr Acting President, whilst I agree that the abortion laws need reform to reflect the advances in medicine, we must, as leaders, always remain focused on protecting those who don't have a voice.